Dr. Pinky. Hi, I'm Dr. Pinky Agarwal, and I would like to thank the Northwest Parkinson's Foundation for giving me this opportunity to present at the online HOPE conference. So today we'll discuss some commonly used Parkinson's disease medications and briefly touch upon how they work. We'll also introduce surgical treatments and introduce the role of diet and exercise in the management of Parkinson's. Briefly touch upon newer therapies in development for Parkinson's disease and research as an option for Parkinson's. Now, around the world, more than 6 million people live with Parkinson's, and they are monitored mostly on the basis of motor symptoms. However, non-motor symptoms often go unreported since they are less visible and more dependent on the person with Parkinson's reporting them. The motor symptoms, as we know, mainly consist of rest tremor, stiffness, slowness, balance problems. Sometimes there can be like a stuttering gait, soft speech. Face can be slightly expressionless or masked. There can be a tendency to fall backwards. Speech can be soft. Some of the non-motor symptoms can include constipation, autonomic dysfunction, which can include bladder problems, bowel problems, sexual dysfunction, drop in blood pressure on standing. Smell can be decreased. There can be trouble with multitasking, depression, anxiety, sleep problems, which can include trouble falling asleep, staying asleep. Sometimes the medications may contribute to impulse control disorders. Along with Parkinson's, sometimes there can be hallucinations, or if it advances, it can even progress to delusions. How the Parkinson's disease medications work? Well, most of the medications aimed for improving motor symptoms are mainly aimed at replacing dopamine. So the most direct and old-time tested medication is carbidopa-levodopa. Levodopa breaks into dopamine and acts on the dopamine receptors. One of the challenges for levodopa is that it's short-acting. We have dopamine agonist medications, which directly bind to the dopamine receptor so that the body thinks it's getting dopamine. The advantage is that these medications can be longer acting than carbidopa-levodopa. We have medications such as MAO-B inhibitors, which can preserve existing dopamine, COMT inhibitors, which can prolong the action of levodopa. This is a list of some of the currently available oral treatments for treatment of motor symptoms. Not actually oral, this includes a comprehensive list of, because some of the medications are through a non-oral formulation. So we have carbidopa-levodopa, immediate release, extended release, a combination called Rytary. Levodopa can also be delivered through an intestinal gel called DROOLING. Then we have inhaled levodopa available as Imbrecia. Then there are dopamine agonists, including pramipexole, ropinirole. And then we have a rotigotine patch, apomorphine, which can be given either as an injection or as a sublingual film. We have MAO-B inhibitors, such as selegiline, rasagiline, cefenamide. And then we have COMT inhibitors, Comtan, Tasmar, opicapone, and a combination of levodopa and entacapone called STIMULATION. And then amantadine can help with dyskinesias, and an extended release formulation called Gocovri is the only medication that's FDA approved, both for treatment of dyskinesias as well as for treatment of off times. In addition, we have a newer class called adenosine A2A antagonist, Norians, which works by a different mechanism. It's an adenosine A2A receptor antagonist, and it can improve off times in people who are on levodopa and still having off time. So I'm just a few additional slides on some of the newer medications for Parkinson's. We have sublingual apomorphine, which is for people who are having sudden off times. And this film can be put under the tongue and it dissolves directly into the bloodstream. And it can turn people on quickly. However, the dose has to be figured out under medical supervision. For some people, they can have some oral side effects like oral irritation, which is why, again, before the dose is finalized, it has to be monitored, both for tolerability as well as for side effects. Opicapone is one of the newer COMT inhibitors. Basically, one medication, one dose once a day can be added on top of levodopa dose, and it can extend the effectiveness people are getting from each dose of levodopa. Imbresia is inhaled levodopa, and the reason one would inhale it is for some people, if they're off and they take extra oral medication, the medication can sometimes just sit in the stomach and not empty into the intestine, which is where the levodopa is absorbed. So, the capsules have to be put in this inhaler, and when it's inhaled through the mouth, it directly is absorbed through the lungs, and it can turn people on quickly. One of the side effects can be cough. And so one needs to be trained sometimes on how to take a gentle breath and maybe take a sip of water afterwards to prevent coughing. There's also DROOLING, which can be delivered to the upper intestine through a pump via a PEG J tube. So the medication, the levodopa, is being directly delivered right in the area of the stomach where it's getting absorbed, so that absorption becomes much more predictable, and people can have improvement in their off times as well as dyskinesias. It is a portable pump, and people can wear it sort of in like a fanny pack around their waist. Brain stimulation and effective treatment for motor symptoms can also help early with people who have refractory tremor. And here at Evergreen, we're doing an observational trial for people who are getting the Boston Scientific System to do some extra assessments for outcomes. So in general, approach to Parkinson's means finding a team you can trust. That could include a neurologist, a nurse, physical, occupational speech therapist, psychologist, part of the research team. Certainly educating oneself so that one can make informed decisions about their treatment options. Exercise, gratitude, focusing on what we have today rather than focusing on what we had yesterday. And then participation in research so that our tomorrow can be better than our today. Diet recommendations. There's no specific diet for Parkinson's. However, a healthy eating plate can be helpful, such as eating whole grains, healthy proteins, fruits, vegetables, more focus on fish rather than red meat, healthy oils, plenty of water, and small servings of nuts, all can be helpful. There is focus on the gut-brain connection. Many people don't notice, constipation as an early sign of Parkinson's. However, constipation can appear early. Thinking that Parkinson's may start in the gut and move its way up the vagus nerve into the brain and then spread forwards from there. So they have found alpha-synuclein in the gut years before the first symptoms of Parkinson's happen. And that may, like this diagram shows, the alpha-synuclein can spread along the vagus up to the brain and then spread from one side of the brain to another. Parkinson's can cause upper GI symptoms, And this can include choking, coughing, having a weak voice. There can be aspiration, extra saliva, trouble swallowing. Sometimes there can be trouble moving food from the front to the back of the mouth, and the food can stick in the throat. Luckily for drooling, we do have treatment options. If there's impairment in swallowing, it is helpful to see a swallow therapist, because they can tell you, how you can eat slower and safer. Chewing slowly can help, clearing the throat before taking bites, eating with a tucked chin. For drooling, it helps to suck on hard candy, sugarless candy. And when the mouth senses there's something in it, it promotes swallowing. And with that, the extra saliva also gets swallowed. Myoblock and Xeomin injections to the parotid and the submandibular salivary glands are FDA approved for treatment of drooling. There is this concept of small intestinal bacterial overgrowth, where when they've looked in Parkinson's, they found that sometimes there is overgrowth of some bacteria in the small intestine, which can sometimes lead to symptoms of loss of appetite, abdominal pain, nausea, bloating. Sometimes there can be diarrhea, weight loss, and lack of nutrition. There can be delayed gastric emptying. When there's delayed gastric emptying, unfortunately, the levodopa also absorption gets delayed, due to which it's helpful for people to separate taking the levodopa with meals. So take levodopa preferentially about 30 minutes before a meal, or wait 60 minutes after a meal. Now, levodopa, sometimes if one eats a protein meal and levodopa both at the same time, then sometimes the protein will get preferentially absorbed versus the levodopa. Hence, the interval between levodopa and food. Gastric function, there can be gastroparesis, and there may be stagnation of food in the abdomen, which is why sometimes people can have early fullness. Having less frequent meals, less frequent meals, exercising, avoiding metoclopramide, which can sometimes be helpful for gastroparesis. However, it is dopamine blocking. And then dietary modifications, such as blending the foods to take down the effort it takes for the stomach to break it down. Constipation, the GI system slows down, and then people can constipated. Some of the medications, especially those used for tremor, or even amantadine, they can be constipating. So a bunch of over-the-counter products, sometimes it needs, working which particular combination works with the person, but that with fluid and fiber intake can be helpful. If multiple over-the-counter products are not helpful, then one may need to see a GI specialist. Sometimes with Parkinson's, there can be weight loss. The loss of smell, sense of smell and taste can contribute. If people have a lot of dyskinesias or extra involuntary movements, those can contribute also to weight loss. Along with that, trouble swallowing, gastroparesis, constipation, all of that can contribute to weight loss. So it's a good idea to monitor one's weight. And however, PD should not cause long-term weight loss. So if one continues to have weight loss, it's a good idea to be evaluated for other causes of weight loss and have that discussion with your primary care doctor. Sometimes after deep brain stimulation, people may have weight gain. Some medications used to treat hallucinations or even motor symptoms of Parkinson's may increase appetite. DBS may initially cause increase in appetite, may increase, weight up to the, it's common to have about 10 to 15 pounds of weight gain after DBS. If it's medication related, such as dopamine agonists causing binge eating, then one needs to bring it up to the doctor so that your medication dose may need to be lowered or adjusted. So overall approach to Parkinson's is finding a team you can trust, which includes your primary care doctor, your neurologist, nurse, therapist, educating yourself, exercising, gratitude, participation in research. In general, there is a vision that every person with Parkinson's who's interested in participation in research ideally would have an option. Broad categories include patients who are recently diagnosed, mainly to look for neuroprotective treatments. There can be trials for motor symptoms like optimizing motor symptoms, treatment of off times, treatment of dyskinesias. There can be clinical trials for non-motor symptoms, such as trials for depression or hallucinations or orthostatic hypotension. And sometimes you can just have trials that don't involve any medications, but are just looking at collecting blood or urine in order to understand and monitor the condition better. One of the treatment strategies for neuroprotection that's being developed is targeting the alpha-synuclein pathway, in which antibodies to alpha-synuclein are being developed, either that can be given intravenously or orally, and that may possibly bind the abnormal alpha-synuclein, form an antigen antibody complex, and then eliminate it. That can be taken up by the phagocytes in the brain. So this is an exciting area of development, and there are several clinical trials going on. So it is here at Evergreen. This is a snapshot of some of the clinical trials available for patients recently diagnosed, which generally means within 3 to 5 years of diagnosis. And we have the LUMA, PROSEEK, TEMPO, Lighthouse trials. Some of these trials are the LUMA trial is for patients recently diagnosed without LOCK2 mutation. Lighthouse is specifically for patients who have the LOCK2 mutation. And then we have PROSEEK and TEMPO trials looking also to slow progression. Again, PROSEEK, like I mentioned, for patients, it's looking at a tyrosine kinase inhibitor, and it's an oral medication. This class of meds has been used in the cardiac world, but now they're looking to see if the mechanism could also help in slowing progression. LUMA, sponsored by Biogen, orally available medication. It is a reversible inhibitor of the LOCK2 kinase. And Evergreen is a proud recipient of the Michael J. Fox grant for increasing diversity in Parkinson's disease trials. And we all hope that we can be an agent of change so that tomorrow we have better treatment options for Parkinson's that are even more promising than what we have today. And so if you had an interest in finding out more about our trials, then that's a website, and that is the phone number that one can reach out to us at. And that I'd like to thank you. And again, I'd like to thank the Northwest Parkinson's Foundation for inviting me to participate in the online Hope Conference. Thank you.